Absorption of a drug. How drugs enter the systemic circulation. Welcome to PharmaconHealth, your gateway to mastering pharmacology with science, simplicity, and clarity. In this video, we begin the first major part of pharmacokinetics, absorption. This is the crucial first step where drugs move from the site of administration into your bloodstream. Without effective absorption, even the most powerful drug won't reach its target. Let's begin by defining absorption and understanding why it matters. Definition of absorption. Absorption is the process by which a drug travels from the site where it was administered into the systemic circulation. It's a vital step. Only drugs that make it into the blood can reach organs, bind receptors, and generate a therapeutic response. But how a drug is given plays a huge role in how it's absorbed. Let's explore the different routes of administration. Routes of administration. There are several routes through which drugs can be administered, and each has unique advantages and limitations. Let's go through them one by one. 1. Oral route or porous mouth route. The oral route, also known as porous route, is the most common and convenient. It's easy to use, cost-effective, and suitable for long-term therapy. However, it has key disadvantages. Absorption can be unpredictable due to food, pH, and gastric motility. And some drugs undergo first-pass metabolism, particularly highly lipid-soluble ones like propranolol or nitroglycerin. These drugs are absorbed through the gut but extensively metabolized by the liver before reaching systemic circulation, reducing their effectiveness. 2. Intravenous route. Intravenous administration delivers drugs directly into the bloodstream. This route offers 100% bioavailability, rapid onset of action, and precise control over blood drug levels. It's ideal in emergencies or when the oral route is not feasible, but it requires sterile technique, trained personnel, and can be invasive and costly. 3. Intramuscular and subcutaneous route. These routes offer slower absorption compared to intravenous route, but they bypass the first-pass effect. They're useful for drugs requiring steady absorption over time, such as vaccines or insulin. However, absorption can vary based on blood flow, muscle mass, and may cause pain or local irritation. 4. Transdermal delivery, through patches applied to the skin, provides slow, sustained drug release, ideal for chronic conditions like pain or hormone therapy. It avoids the first-pass effect and improves patient compliance. But it's only suitable for drugs that are highly lipid-soluble and effective at low doses, since skin is a tough barrier. 5. Inhalation. Inhalation offers rapid absorption through the large surface area of the lungs, perfect for emergency drugs like bronchodilators or anesthetics. It bypasses first-pass metabolism and acts quickly. The main challenge is correct technique, and not all drugs can be formulated for inhalation. 6. Rectal route. This administration partly avoids the first-pass effect, as drugs absorbed through the lower rectum bypass the liver. It's useful when oral administration isn't possible, like in vomiting or unconscious patients. But absorption is erratic, and many patients find it uncomfortable. 7. Mucosal drug routes. Mucosal routes like sublingual and buccal offer rapid absorption and avoid first-pass metabolism, ideal for drugs like nitroglycerin. Nasal sprays deliver peptides or hormones directly to systemic circulation. Vaginal routes are used for local or systemic hormonal therapies. These routes are non-invasive but limited to specific drugs and clinical conditions. Each route plays a distinct role in how a drug is absorbed and used clinically. The way a drug enters the body greatly impacts how it works. Choosing the right route isn't random, it depends on several key factors. Let's explore what guides that decision. Factors affecting route of drug administration. The route of drug administration depends on several key factors. Let's go through them one by one. Number of drug properties. Lipid solubility, molecular size, and chemical stability determine how a drug can be given. For example, insulin cannot be taken orally because it is broken down in the stomach. 2. Desired onset of action. And if a fast effect is needed, intravenous or inhalation routes are used. For slower, long-lasting effects, oral or transdermal routes are preferred. 3. Site of action number local routes are chosen when the drug needs to act directly, like eye drops or skin creams. Systemic routes are used when the drug must reach the bloodstream. Number 4. First pass metabolism number. Some drugs are destroyed by the liver if taken orally. To avoid this, sublingual, rectal, or injectable routes are used. Number 5. Patient condition number. If a patient is unconscious, vomiting, or unable to swallow, non-oral routes like injection are necessary. Number 6. Patient compliance number. Oral routes are convenient and more acceptable for most people. But if the drug tastes bad or requires frequent doses, other options may be better. Number 7. Cost and availability. The oral drugs are often cheaper and easier to use. In some settings, injections may not be practical due to cost or equipment needs. In summary, the choice of route depends on the drug, the patient, and the clinical situation. To compare these routes effectively, we use the concept of bioavailability, which we'll explore next. Bioavailability is the fraction of an administered drug dose that reaches systemic circulation in its active form, which determines its potential therapeutic effect. Intravenous delivery has 100% bioavailability since the drug enters the bloodstream directly. 4. Oral and other routes. Bioavailability is usually less than 100%. Due to incomplete absorption and metabolism, especially the first pass effect in the liver, we quantify absolute bioavailability by comparing the area under the plasma concentration time curve, or AUC, after oral administration to that after intravenous administration. Absolute bioavailability. The general formula is bioavailability if % equals area under curve oral times dose intravenous divided by area under curve intravenous times dose oral times 100. This accounts for differences in dosing between the two routes. When the 4 and oral doses are the same, we use the simplified formula, bioavailability if % equals area under curve oral divided by area under curve intravenous times 100. This tells us the percentage of the drug that reaches systemic circulation after oral administration compared to intravenous route, which is considered 100% bioavailable. This is called absolute bioavailability, the fraction of an administered dose that reaches systemic circulation in its active form. Relative bioavailability. There is also relative bioavailability, which compares to non-for formulations or routes to evaluate how effectively a drug is absorbed in different forms. It's calculated using the formula, relative bioavailability % equals OC of test per OC of reference, times 100, where AUC is the area under the plasma concentration time curve. Let's explain by examples. Example 1. Absolute bioavailability equal doses. Let's say a drug is given both orally and by intravenous at the same dose of 100 mg. After measuring plasma levels, the area under the curve is 60 for oral and 100 for intravenous route. F. Using the simplified formula, F equals area under the curve oral divided by area under the curve intravenous route times 100. F equals 60 divided by 100 times 100 equals 60%. This means only 60% of the oral dose reached the bloodstream in its active form. The rest was likely lost due to poor absorption or first-pass metabolism. Example 2. Absolute bioavailability in equal doses. Now, imagine we gave 200 mg of the drug orally and 100 mg by 4, and the AUCs are 80 for oral and 100 for intravenous. Now we use the general formula, F equals OC oral times for dose divided by AUC for times oral dose times 100. F equals 80 100 divided by 100 200 times 140%. So, in this case, only 40% of the oral dose entered the bloodstream. Again, the loss is likely due to incomplete absorption or liver metabolism. Example 3. Relative bioavailability. Now let's compare to different oral formulations of the same drug. The test tablet gives an AUC of 75, while the reference tablet gives an AUC of 100. Using the formula, relative F equals AUC test divided by AUC reference times 100. Relative F equals 75 divided by 100 times 175%. And this means a test formulation delivers only 75% as much active drug as the reference, so it may be less effective and less adjusted. Bioavailability is crucial in bioequivalence testing, where generic drugs are compared to brand-name drugs. For a generic to be considered bioequivalent, its bioavailability must fall within an acceptable range, typically 80% to 125% of the original, ensuring it delivers the same therapeutic effect. This testing safeguards drug safety and efficacy for patients. Different administration routes vary in bioavailability. Intravenous route is always 100% bioavailable. Sublingual and buccal routes often bypass first-pass metabolism, giving high bioavailability. Oral bioavailability depends on absorption and metabolism, varying widely by drug. Rectal administration partially avoids first-pass metabolism. Intramuscular and subcutaneous injections have generally high bioavailability but slower absorption. Transdermal patches allow slow, controlled delivery through the skin, generally offers moderate to high bioavailability. Inhalation offers rapid and efficient absorption via the lungs, providing high bioavailability for many drugs. Standing bioavailability helps determine dosing, route selection, and assures equivalency between drug products. Next, we will examine the specific mechanisms by which drugs cross membranes to enter the bloodstream. Mechanisms of absorption. Drug transport across membranes. Drugs can enter the bloodstream by different transport mechanisms across biological membranes. Passive diffusion is the most common method. Here, drug molecules move freely from an area of high concentration, like the site of administration, to an area of lower concentration, such as the bloodstream. This process doesn't require energy and is typically used by small, lipophilic, and non-ionized drugs. Facilitated diffusion also moves drugs down a concentration gradient, but with the help of specific carrier proteins embedded in the membrane. No energy is used, but the process depends on the presence and saturation of these transporters. Active transport involves carrier proteins as well, but in contrast, it requires cellular energy, typically in the form of ATP, to move drugs against a concentration gradient from low to high concentration. This method is often used by essential nutrients in some drugs that resemble natural substrates, like levodopa or certain ions. It's a saturable process, meaning that once all transporters are occupied, absorption rate plateaus. Endocytosis is a special mechanism used for the absorption of large molecules that cannot pass through membrane channels. The cell membrane surrounds and engulfs the drug particle, forming a vesicle to transport it inside the cell. This process is slower and less common, but important for macromolecules like some proteins or nanoparticles. The specific absorption mechanism affects how fast and how completely a drug enters the bloodstream, which in turn impacts its clinical effect. Now that we understand how drugs cross membranes, let's explore how we measure the extent and rate of their absorption. Extent of drug absorption. Once a drug enters the body, we evaluate two important features of its absorption: the extent and the rate. The extent of absorption refers to how much of the drug reaches the systemic circulation. It's directly related to bioavailability. The higher the extent, the more drug is available to act on target tissues. The rate of absorption tells us how fast the drug enters the bloodstream, which determines how quickly the patient feels its effect. A drug absorbed faster will generally act sooner, making rate an important factor for pain relievers, sedatives, or emergency medications. We quantify extent and rate of drug absorption using two key pharmacokinetic parameters, Cmax and Tmax. Cmax, the maximum concentration the drug reaches in the plasma. A higher Cmax can sometimes relate to greater efficacy, but also a greater risk of side effects. Tmax, the time it takes to reach that peak concentration. A shorter Tmax means faster onset of action. These values help clinicians decide which dosage form, route, and timing is best for individual patients. Now that we understand how much and how fast drugs are absorbed, let's explore the factors that influence absorption in the first place, starting with the drug's own properties. Factors influencing absorption. 1. Physicochemical factors affecting absorption. The physicochemical properties of a drug strongly influence how well it is absorbed. First, lipid solubility plays a major role. Most biological membranes are lipid-based, so drugs that are more lipophilic or fat-loving can pass through more easily and get into the bloodstream faster. Second, degree of ionization affects permeability. Only the non-ionized form of a drug can readily cross cell membranes because it is more lipid-soluble, allowing it to diffuse through the hydrophobic core of the phospholipid bilayer. The ionization of a drug depends on two factors: the pKa of the drug and the pH of the surrounding environment. This relationship determines the proportion of the drug that exists in its non-ionized lipid-soluble form. For example, weak acids are better absorbed in the stomach because its low pH favors the non-ionized form, while weak bases are absorbed more efficiently in the intestine, where the higher pH promotes their non-ionized form. For example, weak acids like aspirin are mostly non-ionized and absorbed in the stomach's low pH, while weak bases like codeine are better absorbed in the alkaline environment of the intestine. Lastly, molecular size matters. Smaller molecules diffuse more easily across membranes. Larger or bulky drug molecules tend to move slowly or may require transporters. Of course, absorption isn't just about the drug. The body's biology plays a big role too. Let's explore those biological factors next. 2. Biological factors affecting absorption. Biological conditions inside the body greatly affect how drugs are absorbed. Let's explore them one by one. 1. pH of the G tract in drug absorption. The pH of the gastrointestinal tract plays a key role in drug absorption. The stomach has a highly acidic pH of around 1 to 2, while the intestines are more alkaline, ranging from pH 6 to 8. Although some drugs are better ionized or non-ionized in the stomach, the major site of drug absorption is the small intestine, not the stomach. This is because the intestine has a much larger surface area, longer residence time, and a rich blood supply. Some drugs like alcohol and aspirin can be absorbed in the stomach, but overall, its role in drug absorption is quite limited. The stomach has a relatively small surface area, a thick protective mucus layer, and a short transit time. These factors reduce the number of effective absorption sites, making the small intestine, with its large surface area and longer residence time, the primary site for most drug absorption. Most drugs are either weak acids or weak bases. Weak acids tend to be non-ionized in the acidic stomach and ionized in the alkaline intestine. Weak bases are the opposite. They are more non-ionized and thus better absorbed in the intestine. Despite this, both weak acids and weak bases are often absorbed in the intestine because of its favorable physiology, especially the presence of microvilli, which greatly increase the surface area available for absorption. Even if a drug is partially ionized there, the vast surface area and permeability still allow effective absorption, especially if a portion of the drug remains in the non-ionized, lipid-soluble form. Since weak acids and bases are only partially dissociated, an equilibrium exists between their ionized and non-ionized forms. Over time, as the non-ionized fraction is absorbed, more of the ionized form shifts to the non-ionized state, allowing complete absorption of the drug in the intestine. 2. Gastrointestinal. The speed at which the stomach empties and the intestines move significantly affects both the rate and extent of drug absorption. When stomach emptying is delayed, the drug remains longer in the acidic stomach, slowing its passage to the small intestine, the primary site of absorption. This results in a slower rate of absorption and delays the onset of action. If gastric emptying is too rapid, the drug may reach the intestine quickly, leading to a faster absorption rate. However, if intestinal motility is also increased, like in diarrhea or with certain diseases, the drug may pass through the intestine too quickly, reducing its contact time with the absorptive surface. This short contact time can decrease the extent of absorption, meaning less of the drug enters the bloodstream. In summary, G motility affects the rate of absorption, how fast the drug is absorbed, the extent of absorption. How much of the drug is absorbed. Balanced motility is essential for ensuring effective drug delivery and therapeutic effect. 3. Presence of food in drug absorption. The presence of food can either help or hinder drug absorption, depending on the drug's properties. In some cases, Food enhances absorption by increasing drug solubility or stimulating bile flow. For example, griseofulvin, an antifungal, is better absorbed when taken with fatty meals. Similarly, lopinavir, ritonavir, used in HIV treatment, shows improved absorption with food due to enhanced solubility in digestive fluids. But in other cases, food can delay gastric emptying, alter stomach pH, or form insoluble complexes that reduce absorption. For instance, tetracyclines bind with calcium found in milk or dairy products, forming a non-absorbable compound. Likewise, levothyroxine and alendronate show significantly reduced absorption if taken with food. That's why many medications come with specific instructions, either to be taken with food or on an empty stomach, to optimize their effectiveness. 4. G enzymes and drug absorption. Enzymes in the gastrointestinal tract can significantly affect drug absorption. These digestive enzymes, such as pepsin, trypsin, and various proteases, are designed to break down proteins and peptides during digestion. However, these same enzymes can also break down peptide-based drugs or drugs with fragile molecular structures before they are absorbed, reducing their bioavailability and effectiveness. For example, insulin, a peptide hormone, is broken down by proteolytic enzymes in the stomach and small intestine, which is why it can't be given orally and must be injected. Another example is erythropoietin, a glycoprotein hormone that is also degraded by G enzymes if taken orally. Even some antibiotics, like penicillin G, are unstable in acidic environments and can be inactivated by stomach enzymes, limiting their oral use. These enzyme-related challenges are a major reason why certain drugs must be delivered by injection, enteric-coated tablets, or special delivery systems. 5. Blood flow at the absorption site. Blood flow, or blood perfusion, at the absorption site plays an important role in how quickly a drug enters the systemic circulation. After a drug crosses the intestinal wall, it must be taken up by the surrounding capillaries and transported into the bloodstream. If the local blood flow is high, the drug is rapidly removed from the site, maintaining a strong concentration gradient that favors continuous absorption. On the other hand, low blood flow slows this uptake, which can delay the rate of absorption and lower the peak drug levels in the plasma. This is why highly vascular areas, like the small intestine, are ideal for drug absorption, while poorly perfused areas, such as scar tissue or diseased regions, show reduced absorption. In summary, more blood flow equals faster and more efficient drug absorption. Now let's move on to how drug formulation and dosage forms influence absorption efficiency. 3. Formulation factors. How a drug is formulated, that is, how it's prepared and delivered, significantly impacts how well and how fast it's absorbed. Liquid formulations absorb faster because they don't need to dissolve, the drug is already in solution. Tablets and capsules must dissolve first, which slows absorption slightly. However, they are more convenient and have longer shelf lives. Modified release forms, like controlled or extended release tablets, are designed to release the drug slowly over time. This helps maintain stable blood levels and reduces the need for frequent dosing. Some drugs are coated with special materials, called enteric coatings, that prevent them from dissolving in the acidic stomach. Instead, they dissolve in the more alkaline intestine. This protects acid-sensitive drugs and can also improve absorption. But even with good formulation, some oral drugs face a big challenge: first-pass metabolism, which can reduce how much drug actually reaches the bloodstream. 4. First-pass metabolism. First-pass metabolism occurs when a drug, especially a highly lipid-soluble one, is absorbed from the gastrointestinal tract and routed through the portal vein to the liver before entering systemic G or chelation. In the liver, the drug may be extensively metabolized, reducing the amount that reaches the bloodstream in active form. This significantly affects oral bioavailability. Morphine, propranolol, and nitroglycerin are classic examples. They undergo substantial first-pass metabolism and are less effective if taken orally. To counter this, one strategy is to increase the oral dose, but this can increase the risk of side effects or toxicity. A safer and more effective approach is to adjust the frequency of administration, using smaller doses more frequently to maintain therapeutic levels without causing overdose. Alternatively, we can bypass the liver altogether using routes like intravenous, sublingual, or rectal, which avoid or reduce the first-pass effect and improve drug bioavailability. Now that we've covered the liver's impact, let's look at other important factors that influence how well a drug is absorbed. 5. Additional factors affecting absorption. Several other factors can influence drug absorption. 1. Drug interactions, for example, antacids, food, or other medications can either delay or enhance absorption by altering stomach pH or affecting transport proteins. 2. Gastrointestinal diseases, like Crohn's disease, ulcerative colitis, or peptic ulcers, can damage the intestinal lining, reduce surface area, and impair the drug's ability to be absorbed. 3. Age. In elderly individuals, slowed gastrointestinal motility, reduced blood flow, and changes in gastric pH can all alter absorption. Meanwhile, infants may have immature enzyme systems and slower gastric emptying. 4. Genetic variations. Genetic variations, or genetic polymorphisms, can affect both drug absorption and metabolism by altering the function of enzymes and transport proteins. Some people inherit variations in genes that code for metabolic enzymes like for 150 cypriot pounds enzymes, or for drug transporters such as P-glycoprotein. For example, individuals with reduced activity of the enzyme CYP to C19 metabolize drugs like omeprazole more slowly, leading to higher drug levels in the blood and potentially stronger effects or side effects. On the other hand, people who are ultra-rapid metabolizers of CYP to D6 may clear drugs like codeine or metoprolol quickly, reducing their effectiveness in absorption. Genetic differences in P-glycoprotein expression in the intestines can alter how much of a drug is pumped back into the G tract, lowering its bioavailability. So, genetic differences can lead to inter-individual variability in drug levels, response, and safety, which is why personalized medicine is becoming more important in pharmacotherapy. Let's now wrap up this section with a look at key pharmacokinetic calculations that help quantify drug absorption. Drug absorption calculations. To truly understand absorption, we use key pharmacokinetic calculations. As explained before, absolute bioavailability tells us how much of an orally administered drug reaches the systemic circulation compared to an intravenous dose. It is calculated using this formula: F% equals a UC oral divided by a UC IV times dose IV divided by dose oral times 100. For example, if an oral drug has an AUC of 50 and the 4 version has an AUC of 100 with equal doses, its absolute bioavailability is 50%. Relative bioavailability compares to non-IV formulations. For instance, comparing a new tablet to a standard capsule, it's especially useful in bioequivalence testing. During generic drug approval, next is the absorption rate constant, or Ka, which reflects how quickly a drug moves into the systemic circulation after administration. A higher Ka means a drug is absorbed more rapidly, leading to a faster onset of action. A lower Ka means slower absorption and delayed therapeutic effect. This process is usually described by first-order kinetics, using the formula Da dt equals Ka times A, where Da dt is the rate of absorption of drug A, Ka is the absorption rate constant, and A is the amount of drug available at the absorption site. So, the higher the Ka, the faster the drug is absorbed into the bloodstream. For example, a drug with Ka equals 1.2 hours E is absorbed faster than one with Ka equals 0.4 hours. These parameters are vital in choosing the right dose, formulation, and route, especially when designing controlled-release drugs or conducting bioequivalent studies. With that, we've explored the full journey of absorption, from administration to bloodstream. In the next chapter, we'll examine how the body distributes the drug to tissues. Thanks for watching this deep dive on absorption, the first key pharmacokinetic parameter. Don't forget to like, share, and subscribe to PharmaconHealth for more insightful videos. In our next video, we'll explore distribution, how drugs move from the blood into tissues and organs. See you there!